are there any drugs that you can't take when you're progressing with LDN? Perhaps start with you, Sebastian, move down the line with experience.
I get the easy answer then. I get to go first. Well, all opioid medications you have to use in caution, but it's not high-dose opioids that are being entrenched for the patient for an extended period of time, that's where we have to move much, much more cautiously. PRN opioids, we can find a timing of dose and a lower dose, and they can still get some benefit out of. Most of the time, though, we actually see an improvement on their other drug therapy moving forward. So as Dr. Anderson said, as an adjunct care, you see an improvement. I think there was a paper from 2022 that showed that these refractory epilepsy kids that were on high doses of medications all of a sudden came into line, and then we can start seeing this reduction in medications. So other than that, you got anything else?
Opiates, obviously, yes. So at these conferences, I've often told the story of when we first started doing LDN, and there was a patient who said, we're saying, we're not taking any opiates, you're not taking any opiates, you're not taking any opiates. No, you're not. No, definitely not. Again, in the hospital with fits, because she wasn't taking long-acting opiates, but she was chugging on a bottle of Oromorph, every couple of hours, and had been doing so for years, and went straight to the 4.5 milligrams from the liquid, and all hell broke loose. And so it's definitely something which happens. But from a pharmacist point of view, though, looking at drugs that are not compatible, it's also thinking about how you're using them, and when you're using them, and why. So if someone has just started immunologic therapy, don't stick them on LDN as well straight away, because you don't know which one's going to work. So if someone is not stable on a therapy that they have just begun, don't start LDN, because you're not going to know which one of these things actually was beneficial to the patient, or whether it was the combo. So that tends to be a very...
Yeah, I would just tag on to that more than a contraindication, just timing. If they're starting any therapy that has a critical endpoint, such as neuro, cardio, some gastro things, just let them get stable on those therapies and then add it in. Because the other thing is then, if something goes wrong, the LDN will be blamed first anyway. So just get them stable on the other drugs and then add it in. Where I was saying with chemotherapy, we don't worry about that as much as that's sort of a non-issue with most chemo.
With antipsychotics, one needs to take care that low dose naltrexone is going to make these medications more bioavailable. So a person can be doing just fine on their antipsychotic, they take low dose naltrexone, now they're having side effects. They think it's naltrexone. Now it's their antipsychotic needs the dose lowered. I know of one case too with Coumadin, the dose needed to be reduced after they were starting to take low dose naltrexone.
So what sort of period after starting it do you think it should be reduced to a week, or in terms of monitoring, when should you consider a reduction? What sort of time after starting it?
I don't have precise information on that.
Okay.
One other piece to it, though, and this is going to be from the compounding pharmacist perspective, making sure we don't use excipients in our formulations that are problematic for the patient. And I'm just saying, like MS patients, they're very sensitive to lactose. They may be sensitive to magnesium stearate versus another type of magnesium. You may see them sensitive to sugars or dyes or other components. So as compounders, we're also taking that into account. Hence why we don't like taking the tablet and crushing it up and putting it in water, because there's no preservative in the water, and that's going to last them for 10 days, and no one wants to drink moldy water. So things like that, like we're also aware of that, so sometimes working with the patient. So the excipients matter just as much in this case. So,
are there some specific incompatibilities when compounding, just for the pharmacists in the room? Anything that you come across as an absolute no as an excipient combination or a dose form?
Biased comment, or do you want? No, don't use lactose. It's like there's too many patients that are sensitive to lactose. Magnesium stearate, which is very common, just is problematic for a number of patients. So finding something that's inert that will help, that's usually the goal.